Support for this episode comes from Edgepark. You've worked hard your whole life. Diabetes management shouldn't slow you down. Edgepark is your trusted go-to supplier for all things diabetes management supplies and continuous glucose monitors, like Medtronic's Guardian sensor, Dexcom G7, and the Freestyle Libre 3. Edgepark accepts most insurance plans, including select coverage for Medicare and Medicare Advantage plans, and Edgepark navigates insurance complexities for you and handles the paperwork. Learn more, go to diabetes-connections.com and click on the Edgepark logo.
This is Diabetes Connections with Stacey Sims.
This week, we know the importance of mental health support during and after a type 1 diagnosis. So why isn't there much of anything out there? You and I know the answers, right? Time, money, patient and caregiver bandwidth. But can we do something here? I'm talking to an endocrinologist who feels passionately that we can, and his team is trying their best in our difficult system to make a difference. And he's got actionable advice for you, even if your healthcare team does not provide mental health resources. This podcast is not intended as medical advice. If you have those kinds of questions, please contact your healthcare provider. Welcome to another week of the show. I am always so glad to have you here. You know we aim to educate and inspire about diabetes with a focus on people who use insulin. And I'll be honest with you, I expect this episode to be one of the less popular. What a weird thing to say right at the beginning. I know I want you to keep listening, but my point here is that the technology episodes do great, right? Everybody wants to know what's new, what's next, dig into the details of the software, the hardware, and I get that. I really do. But an episode like this, which is a bit more amorphous about mental health, just as important, if not maybe more so, in my opinion. There are some great resources I will link up in the show notes. In addition to the resources that my guest will talk about, I think the Behavioral Diabetes Institute, Dr. Bill Polonsky's group, has just been pioneering in this field and continue to do amazing work. There is the Mental Health and Diabetes Virtual Conference that happens once a year. And a group like TCOYD does a lot of good stuff. But if you're not online with diabetes, there's a really good chance that this has never come up for you, that your endo's in a hurry. Maybe it's your general practitioner who you see, and it's just not built into, the diagnosis and treatment plan for diabetes. So my guest this week wants to do something about that. He is Dr. Todd Alonso. He is the medical director of pediatric services at the Barbara Davis Center in Denver. And yes, I found him when we did Mom's Night Out Denver out there. He was one of the many health professionals I talked to as we were trying to get the word out. And I just loved what he had to say. We did talk a little bit more about my family's experience with diabetes. If you're a longtime listener, sometimes this stuff kind of turns into therapy for me. But I started crying like right at the beginning of this interview, which is really out of character for me. And I almost took out, but I think it's important to leave it in. You'll know why when you hear it. It's just genuine. And I think a lot of you feel the same way. And I will also share that we did a focus group. Sequel MedTech, the makers of the Twist Pump, they did a focus group at Mom's Night Out Denver. And I took part in that. They had a couple of groups and I was in one of them. And I was the first one to cry. And the facilitator was like, well, that took 6.5 minutes and Stacey was first. So yeah, this is emotional. But it's all part of living with or caregiving for this chronic condition. My interview with Dr. Todd Alonso right after this. Gvoke HypoPen is a ready-to-use rescue pen for treating very low blood sugar in people with diabetes ages 2 and above. If you take insulin or sulfonylureas, you're at risk for your blood sugar going too low. Low blood sugar emergencies can happen unexpectedly, and they demand quick action. You need a safety net when it matters most. Be ready to treat very low blood sugar with Gvoke HypoPen. Find out more. Go to gvokeglucagon.com/Stacey. That's gvokeglucagon.com/STACEY. Gvoke shouldn't be used if you have a tumor in the gland on top of your kidneys called pheochromocytoma, or if you have a tumor in your pancreas called insulinoma. Visit gvokeglucagon.com/risk for safety information. Dr. Todd Alonso, welcome to Diabetes Connections. I'm so glad we could set this up. Thanks for joining me.
Yeah, thanks for having me on, Stacey.
You got it. Before we jump in, just tell me a little bit about yourself, where you practice, who you see, that kind of stuff.
Yes, I'm a pediatric endocrinologist. I live in Golden, Colorado, and I practice in Aurora. That's at the Barbara Davis Center, and we're connected to the University of Colorado and Children's Hospital of Colorado. I've been here on faculty for about 11 years, did my training down in Texas, never thought I'd leave Texas. And then this wonderful job opportunity came up. And so moved my whole family to Colorado, and I'm, really happy to serve the community here. We see patients throughout the whole state of Colorado, which is a pretty big state. Some patients drive over 2 mountain passes all the way from the Four Corners area. That's about an 8-hour drive. And you can imagine in the winter, they commute pretty far to see us. It's a really unique part of the country and a really unique community to serve.
So we wanted to talk about mental health. When you see patients, I know it's really important to you, but you're like most doctors, I'm sure you're pretty rushed. What's your baseline? Like when you see a new patient, take us through that beginning. How do you kind of get them into this community? It must be a very difficult visit.
I wouldn't call it a difficult visit. I would say it's probably the most rewarding part of my job to meet a new patient for the first time. And I was just on service over the weekend and, had to have that welcome to diabetes talk with a few families. And, it's a different talk whether you're meeting them in the ICU and they didn't sleep all night or you're meeting them in the clinic a few days later. And my perspective has shifted over the last several years. There's really, I think, 3 different things on that first few days. One is the logistics of, okay, you're going to get discharged from the hospital, and we do outpatient education, which, saves money. And we also think saves a little bit of stress and gets people out of the hospital and in their own bed a little bit sooner. So there's a logistics behind where do you park and how do you get into the clinic and all that. There's also the understanding diabetes part, and there's more and more really good resources online. Of course, there's some not good resources. So we like to point our patients the right direction. And then there's just like, how do you feel about things? And what I've found myself doing in the last few years is, giving people a diabetes lecture at a chalkboard and drawing a pancreas. I don't think it serves them very well on that day one. And I just stopped doing it. I'm a bad artist, so it, probably saves some people, some angst just having to watch, my blobby pancreas up there. But I really focus on, how you feel more than what you know on day one. And I want you to know that the children's team that took care of you overnight did a good job. And I'm really happy to see your child's doing better. And I heard your story and I saw their labs, and I'm really glad that things have turned around. We have the right diagnosis. I want you to trust me and trust the team. And then I'm going to talk a little bit about logistics. And then I emphasize those things, that hopefully you heard as a parent, Stacey, when you entered into this world, that it's not your fault. And most parents, either make a face or they start crying right there because that's so powerful to hear that.
I'm going to interrupt you because it's 17 years later and I am now crying. Why does that happen? I know it's not my fault.
Well, I mean, that's the first message that I think every family needs to hear, right? Because every parent is sitting there, and every parent I've ever met says either internally or out loud, I wish I could take this diabetes from my child, and I wish I could have the diabetes and not them. And what did I do, right? There's so much stigma. It's so undeserved around all types of diabetes. And I think that's kind of where I'm getting to with the mental health. It's what you bring in the room with you. I really want to speak to that first, because I think that's the first thing that families need to hear. The second thing that I say is that I expect your child to be okay. She's going to be okay. And I really hope and expect this is the last time that diabetes puts your child in the hospital. And for the families who didn't come in through the hospital, I say, I hope that you're never there for diabetes. But, and this is a big but, and I've listened to enough of your episodes, Stacey, I know you and your audience understand this well, that if we're going to do that and we're going to do that well, you're going to have to be a diabetes expert. And this is going to be really hard work. And then we get down to some of that hard work. And I say, I'm going to get out of the way and let the nurse come in and teach you all the practical things that you really need to know today. And then when we circle back, we have a lot of team members. We have a social worker. We have a couple social workers on our team, and they meet with the families during the intake process. And that conversation starts with, tell us about your family structure. How many households do you have? Who lives at home? Who takes care of your child? And then what other, mental health challenges and social stressors are already with you in the room as you come into diabetes? And you can imagine families that have more stressors already coming in. It's going to be a more difficult journey. And it's really important for your healthcare team to understand that and to understand you. I mean, you deserve to be understood, because then we can craft a plan and a diabetes treatment that really fits your needs. And so maybe starting a CGM in the first week or the first month isn't the right choice for your family. I know patients do really, really well on CGM, and I really want to see my patients on a CGM as early as possible. But for some families, we should hit the brakes and maybe deal with the needle phobia, or what other challenges did families bring in? So we do that assessment early on. I try to spend some time in that space to understand my patients and my families. And then our social worker having another 45 minutes beyond the conversation that I had, they're able to dig a little bit deeper.
Does a social,
Yeah.
and we're going to circle back
Oh, yeah.
to a lot of these things, because I know a lot of people listening already threw their phone going, what do you mean no CGM in the first week?
Yeah.
So we'll get back to that, because I know that's a hot topic. But do all of your patients get a social worker?
We do. We have a
That's
social
amazing.
worker meet with all of our patients at our day 2 visit. We used to
Wow.
do one mega visit for
Yeah.
7 hours on day
Oh
1.
my God.
And people looked like zombies. And we finally, after years, said, maybe we need to do something different. So we split it up. And so it's usually day 2 in the clinic. We have a meet with a social worker. If I had my magic wand and a really large bag of money, I would have more social workers on our team. We have amazing social workers, but right now there's only 2. We have the need for 7. We have
the need
have,
for more than
yeah,
0 where I am.
right. We just went from 1 to 2 pediatric psychologists. This new psychologist we just hired last month, I'm really excited to have her on the team. She already knows and understands diabetes really well, has worked with kids with diabetes for a long time. And she's going to be primarily clinical. And we have a new fellow, psychology fellow, coming in next month. And this is great for our team, but we serve 4,000 children and adolescents and young adults, and the resources are not there. And it's a broken market is what it is, Stacey. You know, like when people talk about childcare as a broken market, like you have to pay more for your childcare than you're making when you go to work, right? That doesn't work.
Yeah.
The finances for paying our mental health workers, our society largely from a financial standpoint, we pay lip service to mental health. We're talking about mental health a whole lot more and a lot more positively, and we're much more open to that conversation than we were when I started my career. So, 10, 15 years ago, a lot of that stigma has dropped, and my patients are, even people I've never met before are much more open about talking about their mental health. And we haven't gotten to the point where the policy and the money is following. I really hope that that's change that we see in the future. But it drives me nuts that we have to talk about mental health with the word mental in front of it to qualify it, because it's just health,
Yeah.
right? Can we just talk about it as health? Maybe that's somewhere that our society is going to go. I think that enough of us recognize that and recognize how mental health can be such a barrier to all of our other health conditions. And anytime I see a child with an A1C over 10, I don't need to convince them to take their insulin. I'm not going to talk them into taking their insulin or checking their blood sugar. There's some other barriers there. They don't need much diabetes education. It's usually not the case. It's usually, we're dealing with anxiety and depression and disordered eating and family conflict and ADHD and all these other things that really have to be in the front of the conversation before we can get down to the nitty-gritty and diabetes management.
Yeah. I'm curious though. Okay. I'm trying to remember our experience. And like I had said earlier, it's a long time ago. But I do remember going home. We had contact with the doctor a lot. This is a long way to ask this question, so I'm just going to, I'll get to it. When you see people in follow-up, I know anecdotally from Facebook groups and people I talk to, everybody gets super number focused. We are going to get this number. We're going to be in this range. We're going to do this right. We're going to be the perfect diabetes parents. And they're not necessarily thinking about all of the other, I'll say it, mental health, because that's what we're talking about, not just health, but they're not thinking about all of that, the stress on them, the stress on the kid, the stress on the whole family. It's more, how do I make sure that we are in range? And while that's really, really important, anything you would tell those parents in that time? Like,
oh gosh. Yeah, that's such an important point you bring up, Stacey, because what other disease gives us so much objective data?
Yeah.
Right. Which at the beginning, that feels like such power to manage this disease, or dare I say, even try to control it. I hate saying that word because we don't control diabetes. We manage. We teach our patients to live with this disease. So, what I try to emphasize to parents first, going home on the first day, I'm going to give you enough insulin that it's going to keep your kid out of the hospital for the next few days, but not so much insulin that you have to go back to the hospital. And, we all giggle about that. And I say, what I mean is I'm going to tolerate some blood sugars the first couple of days. As you get back home, you learn to give these shots. You learn to start counting carbs. You're going to make a few mistakes because you're human. And we're going to tighten the screws a little bit, but I don't want you to be so focused on the numbers. If your child has a low blood sugar, I want you to treat it. And then I want you to, if your child has a high blood sugar, check the ketones like we taught you to. And as long as we're on top of those things, no number on your glucometer is going to freak me out. And so I tell families that, and I even ask them to check it at 2 a.m. That's our clinic practice. That first week, I want you to check around 2 a.m. If they're not low, I want you to go back to bed. I don't care what the number is. Aside from that, I'm just data collecting, and it's going to become actionable in the future. Going in the future, as patients are more experienced with diabetes and we get very good at managing diabetes, our patients get really smart. They've learned what foods blow up their blood sugars. They've learned all these tricks, all these things that I couldn't have taught them, that they had to learn just day to day through life. And of course, we enter this honeymoon period where the beta cells wake back up and the blood sugars are curiously stable. We start to have these conversations around what are our goal ranges for these numbers, but what is our big picture goal? And so one of the things I like to say to families is, you and I have the same goal, and it's, I want your child to have a happy life. That's what we're after. We're not after an A1C number. We're not after a number on that glucometer. And there are many times that when my patients have a lot of stress in their lives and even mental health struggles, that we talk about giving up a little bit of A1C. And especially if you come in and your A1C is 5.4, Stacy, I don't think the literature, and I hope that your callers don't, call in and tell you that they hate Dr. Alonso's comments here. I don't think the literature supports the necessity of winning the A1C sweepstakes. I don't think you have to have the lowest A1C possible to optimize your health. I think
those people have left this show a long time ago.
Right.
Trust me,
and I say this, as a scientist who critically evaluates the literature. I read, the literature. I read the reports from the ADA and our guidelines that we get from the American Diabetes Association and from the ISFAD, the International Society for Pediatric and Adolescent Diabetes. And those goals of A1C below 7.5 are really well placed. Somewhere below 7, your chances of having long-term complications appear to evaporate. And I have patients who come in, their A1C maybe 6.1, and yet their anxiety is off the charts, and it's clearly very disabling to them, and it's causing trouble with their relationships with their friends. And we say, maybe there's somewhere in there that we can soften some of our attention to diabetes in a safe way that you can live the happy life that we're actually shooting for. And I have that conversation. It takes different forms with different patients, but I think it's really important to acknowledge that, you are not a number, and the numbers guide us and they help us, but they're not the ultimate goal of what we're doing.
I hesitate to ask this question, but I'll ask it anyway. How difficult has social media made those conversations? Because I'll share that before social media, and my son was young, so he was diagnosed. We like to say he was diagnosed before the iPhone. But I've been very active on social media since, I don't know, Benny was 7, let's say, probably a little bit younger. And as soon as I got on Facebook, it was very comparative. And I started to feel really bad about a lot of his numbers. Now, I don't share his numbers. Because I got really good advice from a friend of mine who had a kid who was older. And she was like, why are you doing that? Stop doing that. Nobody needs to know. It's nobody's business. And I did stop. But he was fine, like his whole childhood. He was fine. I mean, it was nothing, we never had an A1C under 6. But we never had an A1C that was alarming until puberty. And then we fixed it with help from our endo because he's amazing. But it still haunts me. I still feel like I've done things wrong, even though he's 19 years old. And of course I've done things wrong. So that's parenting. Okay, so that's my editorial comment, is that social media has helped me in many ways by connecting me to wonderful people. But it's also been really, really hard when I look at the comparative nature of it. Does that make sense? Right back to our conversation. But first, Diabetes Connections is brought to you by Omnipod. It used to be that you would have to choose between an automated insulin delivery system and the freedom of a tubeless device. Now, with Omnipod 5, you can have the best of both worlds all in one. Omnipod 5 adapts with every pod change to meet your unique insulin needs and adjusts insulin using a customized target glucose, not a range. If you're ready to ditch the multiple daily injections or send your tubed pump packing, there's never been a better time. They'll even check your insurance coverage for you. Fill out the quick online form, see if you're eligible for a free trial. Go to diabetes-connections.com and click on the Omnipod logo. For full safety risk information and free trial terms and conditions, visit omnipod.com/diabetesconnections.
Oh, absolutely. Yeah, I totally know what you're saying, Stacy. That's, some of my colleagues in medicine strongly discourage families from going on the internet and learning things about diabetes. I think that that's bad advice, honestly. I think that the good advice is the internet is a really powerful tool and it can be used for good. And there's a lot of really good diabetes resources out there. And I tell my patients, if you're going to look at a CGM, go to the industry website and look at their YouTube video because it's professionally made and it's really good. But don't be afraid to look at other YouTube videos where individuals are placing their CGM on and maybe using something like a wooden spoon to get the inserter unstuck. That's the kind of advice that our diabetes educators wouldn't know if families didn't talk about it. And I remember reading in your book about, the first Dexcom Share that you guys had. And if you'll recall, and some of your listeners may remember, before Dexcom Share came out, there were individuals who were hacking their own devices and doing basically the Dexcom Share thing off the grid, right? And it showed industry that, hey, this is actually a really necessary thing that parents are clamoring for. And I totally respect families who are going to seek out information. And what I tell them is, also, here's my caveat, crazy people like the internet. So if
crazy people give advice on the internet.
Oh, yes. And it's, but I'm not afraid of you reading that and seeing it. But if it sounds really different from like what we have talked about here within these walls, let's talk about it.
Yeah.
I want you to bring it up, and if you saw something really interesting about cinnamon and diabetes, why don't you bring that up with me? And we can have that conversation. And, I've read the literature and I can talk about okra water and camel's milk and all the other things that pop up from time to time. So I think that if you walk into that level-headed, realizing that, the internet is a source of good information and bad information, I'm going to do my best to filter it. And then I'm going to filter that through a trusted source. And I want to be that trusted source for my families. And so I try to make it clear to them that any question you want to ask me, anything that's too off the wall or weird or hard, I don't mind if I have to go look something up and read a few papers before I get back with you.
I think people are worried too that you're also busy. Like I hesitate a lot before, and I ask our endocrinologist very little because Benny's 19. So he's doing it all himself. But for years, I was always worried like, oh, am I calling too much or am I going to email him too often? And he would always say the people who think that about themselves never do. So if you're thinking, I guess, is it true? Like if you're thinking, oh gosh, I don't want to bother the doctor, go ahead and bother the doctor.
Well, I think, when I receive messages sometimes that, and not just from my families, but messages that I don't feel like responding to in the moment, I batch my work and I take care of the other things that maybe pay the bills today and I'll get around to responding. But yeah, when the families that I take care of, when they message me, I respond to those messages and I try to do so with kindness and with understanding that, everybody's walk with diabetes is different and everybody's anxieties are different. And some of the families I care for don't have very much confidence in adjusting their child's insulin. I feel like they could probably do it on their own, but they don't feel confident in not asking yet. And I don't judge them for that. I say, thank you so much for asking. Let's try these adjustments. And, whatever your needs are and whatever the next person's needs are, that's what your healthcare team is for. And if you have a good relationship with them and you have good continuity with your team, and I've heard you, speak about Dr. V and sing Dr. V's praises, and that's a relationship that a family with type 1 should have with their endocrine team, that, no question is too ridiculous and this is okay. And I like it when families, invite me to their kids' high school graduation or their baseball game. And even if I can't make it, to that event, I appreciate it that like, you feel like you can reach out and ask me questions and we can talk like a couple of reasonable human beings.
It's funny, Dr. V, and I did that because I felt that when my child was a minor, we wanted very little information out there about Benny and even who we saw. But it is Dr. Mark Vanderwell. I'm allowed to share his name. Not that he never cared, but Benny, but he's like, just tell everybody. And he's amazing. We're so lucky. And we were lucky that, gosh, to have the same doctor from ages 2 to 19. And now a couple more years he can stick around. So quick shout out to him and the whole team at Atrium here in Charlotte. They're incredible. And I should say, when we're talking about calling the doctor, the 24-hour hotline, like that's a different thing. You call that when you need that. That's a different thing.
Right. That if you wake up somebody at 2 a.m, that's the fellow who's, she's a pediatrician and she's in training to be an endocrinologist. And, you're waking her up at 2 a.m. and she doesn't know you very well. So if you have a question that can wait for the light of day and for business hours, you're going to get a better answer. But I also tell families too that first week, I think everybody makes at least one unscheduled call after hours the first week.
I made 30. I called 30.
At least one.
I called once a day.
Right.
I tried not to call overnight. I called once a day. And then on the 31st day, I called them and said, I'm just calling to let you know, don't worry. I don't have a question, but I didn't want you to be scared that I wasn't calling you. And they all laughed. And, but it's true. By the way, as you listen, I have a great episode. It's like the top 10 questions endocrinologists get. And we do talk a lot about when to call in the middle of the night and when not to call, or, when it's appropriate. I'm trying to think of the better way to say that, when it's a good time to call, really when the difference between urgency and when it can wait. So I'll link that episode up as well.
Yeah, I appreciate that.
Todd, let's go back to this not necessarily, I don't want to say no CGM, but not necessarily giving you a CGM the first week, because here in Charlotte, North Carolina, several years ago, we started getting this influx of questions in our local parent group. And it turned out that one of the pilot programs for giving kids a CGM in the hospital at diagnosis was happening here. So a lot of parents were experiencing something that we didn't experience, and most of us hadn't experienced, which was, here's your diagnosis, here's your information, here's your insulin, here's your CGM. Can you talk a little bit about why you don't always do that? Because I know that there are many parents who think that you absolutely must. It's a non-negotiable.
Right. That's such a good question. So first thing, Stacey, to go back to my earlier comments, I'm a CGM zealot. If I'm a father of 4 boys, if one of them was diagnosed with diabetes today, we would have a CGM on them before the sun went down. But I say that knowing what a CGM is, how it works, and understanding a lot about diabetes management already. And so I feel like my on-ramp and my family's on-ramp would be a lot quicker. That first day going home and the logistics that you have to do, and that first shopping trip you take that takes 3 times as long as normal because you're looking at labels and figuring out school and childcare, and do we really need to be troubleshooting connectivity and setting up an app on day one? I'm not saying it's a no. What I'm saying is, for some families, that becomes a one more thing that would be better put off and done better if we waited a day or two. The other thing is, for some of our insurers, if I pull a CGM off the shelf, we still get samples of those from the manufacturers, and we do have a limited number of samples available. And I could pull it off the shelf and put it on a child today in clinic, but I just extended your new onset visit and you got out of the ICU and you didn't sleep much and you haven't eaten much in the last 3 days. I just extended your visit by an hour and a half by doing that. And I can write the prescription and we can send it in. Once we sign my clinical note, the insurer needs to see the note. Sometimes they need to see multiple pages of PDFs. That's kind of a crazy thing that standard of care requires so much more documentation. I wish that would go away.
Yeah.
But to get a CGM in your hand, paid for by your insurer, might take 3 or 4 days, might take a month. And we've seen cycles, and I think the cycles depend on how well staffed some of those offices are between the supplier and the insurer. And the last disservice I want to do to a family is to give you a CGM and make you feel like that's the only thing we ever knew, so that if I had a day without a CGM, I would feel absolutely paralyzed and afraid that I can't do diabetes this way. And I'm the medical director of a diabetes camp. I love spending the week at Camp Colorado every summer. And if a child's CGM comes off, if their insulin pump comes off, and we have to go back to MDI and finger pokes, and God forbid, if we ever had to go back to using NPH, I know we could handle it. I don't want to put a child on NPH, and I certainly don't want to do it at camp. But, if my hands were tied, I know that we can do this and we can keep the children safe and do this. And I want you and your family to know that if I didn't have a CGM for a night or two, it's okay. I don't want you to have a lot of nights like that in the long run.
Yeah.
So what I do tell families, we give them the Pink Panther book that's published from our center, and we'll hand them the book and say, this is, remember at the top of the interview, I said that there's the 3 categories of things, that kind of understanding all the details of diabetes, that's in that book. Why don't you go read that outside of our class time, and we'll catch up with the differences between type 1 and type 2 later. But you can jump near the end, and I want you to read the CGM chapter. And I would love to see every one of my patients on the CGM within a first month. And honestly, if we're making that decision in a week, we have the 1-week class. It's about a week in for people's diagnosis. We have a now not optional, but now, I'd say required, but it's a part of the class. It's an expected part of the class that everybody attends, not just to be sold on the idea of getting a CGM, but understanding how the CGM works, some of the tricks. We started doing this several years ago as the CGM devices got so much better, and we realized this really should be the standard of care. We really should offer a CGM to everybody, and we should do it very early on. And more data has emerged in recent years showing us that, yes, that's the right choice. And so I do, my long answer to your short question, Stacey, is I would love to see everybody on a CGM and continuously on a CGM starting very early after their diagnosis. But in some situations, in some families, it's not the right choice
Yeah.
to do early on.
Yeah.
And, above all, I want to respect my patients' decisions. And I want their diabetes treatment to be something that we have worked on together as a plan. And it's not the doctor imposing the regimen.
So I want to talk about if you had a magic wand, right? What kind of mental health or health overall
Mm-hmm.
information, resources, advice you would give to parents? But I have to kind of add into that question, I feel like you guys have everything there. Like
Oh,
I know you feel like you don't have enough, but oh my gosh, it just sounds amazing to me. And we have it good here, but we don't have all that. So I guess I'll stick with my question, but just with the line in here as you listen, like, doesn't this sound great? Just the bare minimum. It sounds like the bare minimum to you,
yeah.
Todd, but we're all like, wow.
Yeah. Well, before I pull that wand out of the sheath, let me first acknowledge that I work with a really, really wonderful team of people who are so passionate about what they do for families living with diabetes. And I'm so thankful for everybody's individual expertise and what they bring to the team. And it's no matter how good it is, and no matter how good any diabetes care is anywhere in the US, and I've seen the data, it's not good enough. We're far behind Europe. And I would refer your listeners back to your interview with Jen McVean a couple months ago, where she talked about A1C and the trends in the US. Like, our tools aren't good enough. So magic wand out, specifically pointing at the mental health piece. I would like to have all of my families have more contact with a mental health provider very early on. I would like to further destigmatize mental health services so that families feel like it would be an expected part of diabetes care that maybe I meet with a mental health professional at least once a year as a check-in, at the very least. I would like to see our clinic do more. This is where I reveal what a nerd I am, more structured, objective, standardized assessments. Because if I'm going to assess somebody for depression, we can sit and have a meandering talk about depression, but there's actually validated tools that help me as a clinician be much, much better at that part of my job. And so employing those tools and using those in the clinic presents a technical challenge. And we've overcome that to some degree by using tablets. And we have some computer logic where the computer knows who deserves what questionnaire when. So we've just begun within the last year using that. I would love to see more expansion of that. Not that we all love more surveys, but I want to use the technology to allow our team to have a more rapid assessment of what you need.
Yeah.
Because I feel like, at least in, when I'm meeting with patients, I probably spend half of my energy in my time trying to figure out what you need. And if I could accelerate that part of the conversation, then I could spend the rest of my time actually giving you what you need. That's my vision for what healthcare should look like. And so by the time you walk in the door, if I knew that you need your prescriptions refilled, and we didn't even have to talk about it, but I could just click, 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 and be done with it, then we can move on and not talk for 3 or 4 minutes about that. I would like to have that assessment extend to mental health. I would love to see a better integrated health model where the mental health provider is integrated to my clinic and has enough capacity to serve all of my patients. So we do have that integration now, but we don't have anything close to that capacity. And the reason that's so important is an integrated mental health model, patients have better outcomes. When you have your psychologist in the clinic, in the diabetes clinic, in the GI clinic, and whatever clinic, there's data across the pediatric spectrum that have that integrated healthcare. It does a couple of things. One thing is there's better connection between those team members, and we understand your needs better and we can serve you better. Having a psychologist who specifically works with patients with chronic disease or with type 1 diabetes, there's not a lot of those out there. If you could at least find a mental health professional who works with people with chronic disease, they're going to have a leg up on understanding the challenges of managing this disease, this very, very unique disease that has such tremendous demands on your ability to understand your body and manage everything in your life from A to Z. Just this morning, I spoke with a therapist who's seeing one of my patients, and it was a really good conversation. She was reaching out. She said, Todd, one of your patients is seeing me. She signed the release of information. She wants me to talk to you a little bit about where diabetes and her health intersects her mental health, and talk to me a little bit, help me understand diabetes in her life. And so I was able to talk about how conscientiousness is good, but at some point it bleeds into anxiety, and how focusing on your food and your diet is good. But then when you cross that with body image questions and, and concerns about food feels like the enemy, I know that people with diabetes live with that thought very often. anyway, I was able to talk about that with the therapist who now has a little bit better understanding and hopefully can serve my patient better. But I wish that person in that role was constantly connected to my clinic and just understood that intimately and worked with people with diabetes day in and day out. So magic wand, Stacy, I would love to see more evidence-based training programs that would accelerate the development of this workforce. I would spend the rest of the fuel on my magic wand fixing the financial aspect of it, because what happens, and I don't recall if you've talked to your listeners about this before, but when the money that insurance pays to reimburse for mental health services doesn't keep the lights on.
Right.
So those negotiated rates don't work. And so what happens in a hospital system, like at our local hospital, the challenge has been that you can have a really good psychologist seeing patients, they serve your families really well, and yet the hospital says, well, to eat what you kill and to keep the lights on in this practice, we need to give you more and more and more patients. And at some point, that provider says, this is really hard, taxing work. I'm burned out. And they leave and they go to private practice, and it's a better job, and they continue to serve some of the community. There's not nearly enough providers out there to serve all the community, but then they become a cash pay business.
Yeah.
And so which of my patients don't get served in that model? It's my patients that are low resource to start with, which I would argue feel like they need the help even more. We see disparities and inequalities and outcomes, and the data are published. It's really clear that we need to do more to acknowledge this equity gap. And that's how this broken market, my wand would fix that. So I'm trying to remain optimistic.
No,
Stacey.
that's okay. It's realistic. And I think it's important to focus on that. We don't have to make it sunshine and rainbows.
Yeah.
It's a real problem. And I think just in the last few years, it's a problem that more people are willing to even acknowledge that access is an issue, and barriers to access has real health outcomes. I think there were many people who thought, well, it works out.
Can I answer your question just a little more detail there?
Of course.
Because I want your listeners to hear this. In my ideal world, sunshine and rainbows, I would like you to see a really well-trained psychologist who has been really educated in evidence-based methods. And so just like I give insulin for diabetes, I don't give penicillin for diabetes. I would love to see the best trained person who's going to give the right therapy for your condition. However, if that person's not available, if you met with that person and you didn't feel like they understood you or they heard you, or it was a really long drive, or the out-of-pocket cost was too high, then I want you to find the therapist that you can find. And, the question that you would ask, that I ask my patients are, does your therapist understand you? Do you like your therapist? And if the answers are yes to that, then that's the right therapist for you. So I'd love for you to see like the A++ best trained person. But if that's not available, I want you to see somebody who's available, who you will engage with.
Before I let you go, I'm always curious about this. What works? And I'll ask this from a parenting perspective, not from a patient perspective, which I know is a very different answer. But you've probably seen some patients go from adolescent to adult, or, young child to older adolescent in your time in practice. And what kind of, I know this is a really loaded question. I was going to say, what kind of parenting works? I don't know about that, but what's important for parents to keep in mind? Because you've already basically said it's not only about the numbers.
Mm-hmm.
So what works?
Yeah, I wish that, a part of what we could do is I wish we could offer some parenting classes. I wish that was a part of our curriculum and something that was optional, because I think some families, maybe didn't receive that training at home as children on their own, and then they become parents and maybe haven't gained those skills. And, being a parent, there's a lot of balance to strike, right? It's just like a diabetes balance, where we're kind of trying to find this balance between, warmth and permissiveness. You could think about a 2x2 grid. I want to be very warm and responsive to my child, but I can't be overly permissive. And I can't be a walk-on and a pushover. I need, as a parent, to be very warm and loving and understanding, but I also need to make it really clear that early on with a very young child, right after diagnosis, checking your blood sugar is not negotiable. Receiving your insulin is not negotiable. And the families who do that really well, I can see it on day one when I'm in the exam room, meeting with the family the first time. I have parents who display a tremendous amount of anxiety to their child when they go to give that shot the first time. And when I see that, I try not to let them hear any judgment in my voice. I'll let the moment pass. And I try to speak to them and say, now, it's going to serve your child the best if they don't see your anxiety in that moment. The best thing you can do is be a technician and get this done and do it with warm love. Because when you give, one of my
I'm sorry.
mentors,
We're going to get back to that. I'm cracking up with the worm. I'll tell you my story in a minute, but go ahead.
Yeah. But it's so hard, right? Because people come in the door with needle phobia and that's real. And so just being able to acknowledge that and, how well can you suppress that in the moment? I don't want to sound like I'm judging families with that, but when you're ready for a little bit of redirection, what I try to tell families, I was told years ago, giving insulin is giving life. And I think it's important for some families to hear that when you frame it like that, then it's like, okay, give me the pen.
Yeah.
We're going to do this.
Yeah. And just to finish my thought, I was laughing because Benny was 23 months old. And so he was like, why are all these people stabbing me? I mean, there was no comprehension. So it was not warm and loving, but it was, because what we would do is for the first 2 weeks, we would like grab him, get him in a hug, give him the shot, and he'd be very upset. And then immediately he would be fine. And we would praise him and we would love him. And then I would go in the shower and cry. That was how we did it.
You did it right.
Oh, thank you. It didn't feel technical. It didn't feel, like I was doing anything right. It just felt insulin is life. We have to get this done. But it did serve us well to kind of hide that part from him and make it matter of fact. Dr. Vanderwell always said, it's got to be like brushing your teeth. Eventually you'll get there. And we did. Right. We did.
Yeah, I think that's really important to do. And it's just a non-negotiable. It doesn't feel really good in the moment. And as a parent, and I say this as a parent, there's things we have to do where we have to swallow a little bit of pain for our kids. And I've had a raging toddler of my own before. And in the moment, I need to be the adult. And what love does he need right now? And I think you have to bring that out. And in diabetes, boy, it's going to test your limits because it's really hard.
I brought you on the show because we were going to have this highfalutin conversation about mental health. And I feel like we've had a great conversation. It has been a bit all over the place, but that's what always happens when I get to talk to great endos, because I love to find out what you want to talk about and what's going on in your practice. So you've been doing this for about 11 years now.
Right.
And a lot has changed. I mean, these 11 years have been really interesting when CGM,
absolutely,
hybrid closed loop systems. I mean, who knows what's coming next? There's some really interesting things on the horizon. Are you still excited getting out of bed, going to work? Is this still really what you want to do?
Stacey, I told you earlier, I work with the best team and I have the most fulfilling job. I have a really wonderful job and I really love the people that I get to work with, both my colleagues and the families that I get to serve. And it is so wonderful knowing that we have better tools today than we had yesterday. We have better tools in the pipeline. And when I talk about tools, I'm not just talking about CGM and insulin pumps. As we've moved with that technology, we've seen our A1C across our clinic drop. We've seen our median A1C, come down. Wow. Our time in range is going up. Patients are experiencing much better outcomes, fewer severe hypo events. And we track all this data. And so I can see very objectively that things are getting better, but it's also an acknowledgement that we are nowhere near where we want to be. And I'm really excited about the fact that we finally have a drug that modifies the autoimmune process that's going on in the body. The teplizumab that was approved, November of 22?
22,
when it was approved, and we started infusing it a few months later at our center. And knowing that there's more drugs in the pipeline behind that population screening is going to be a thing. We're going to be screening children for autoimmunity. That looks like the path we're gonna go. And some of the projects that I'm working with is helping us understand the business case and the cost effectiveness. How do we make screening cheap enough and prove that we save enough money that it's a widespread thing that insurers are willing to pay for and that we can operationalize. So I know that there's a lot more change that's coming, and it's going to be really good change. And the families that I serve really deserve that. And so I'm really excited to be a part of delivering that.
I love it. Dr. Todd Alonso, thank you so much for joining me. I hope you'll come back. This was a great conversation. I'd love to talk to you again.
Yeah, I'd love to come back and talk to you more, Stacey. Thank you so much. And I wanted to say thank you for the niche that you fill in the diabetes sphere with this show. I really feel like, the voice of the patient is such an important thing. And I've enjoyed listening to some of your podcasts recently. And I'm really glad that, families can connect and listen to your perspective and all the great interviews you do.
Thank you so much. Wow, that means a lot. Thank you.
You're listening to Diabetes Connections with Stacey Sims.
More information in the show notes, of course, more information about Dr. Alonso and the resources of Barbara Davis, which are pretty unbelievable. But like I said at the beginning of the show, there are other online resources that you can look at, you can share, that I think are extremely helpful. And I will link those up as well. This was a longer interview than usual, so I will just quickly say, in terms of Mom's Night Out, We're closing registration for Philadelphia pretty soon, October 20th. That event is October 25th and 26th in Cherry Hill, New Jersey, a suburb of Philly. And we are opening registration for Atlanta. Mom's Night at Atlanta will be the very last weekend of January 2025, January 31st through February 1st. And all the information is over at diabetes-connections.com. Just click on the Mom's Night Out tab. Super excited for Atlanta. Thank you to my editor, John Buchanan from Audio Editing Solutions. Thank you so much for listening. I'm Stacey Sims. I'll see you back here soon. Until then, be kind to yourself.
Diabetes Connections is a production of Stacey Sims Media. All rights reserved, all wrongs avenged.
The all-new Dexcom G7 continuous glucose monitoring system is now available. Powerful and simple, Dexcom G7 is proven to lower A1C and help you spend time in range, all without finger sticks, scanning, or calibrations. There are so many amazing new features to talk about, I'm never sure where to begin. Dexcom G7 is 60% smaller than the previous generation and is the most accurate CGM system out there. The 30-minute warm-up period is fantastic and up to 2 times faster than any other CGM brand. And I love the all-in-one sensor and transmitter. To learn more, go to diabetes-connections.com and click on the Dexcom logo.